Good afternoon everyone. Today we have our third lecture in this series of ABG interpretations, and we'll be dealing with metabolic acidosis today. We'll be dealing it in two parts. One would be normal anion gap metabolic acidosis, and in second part we'll be dealing with high anion gap metabolic acidosis. We'll be covering the pathophysiology, we'll be covering the algorithm for evaluation of HAGMA and NAGMA, and the treatment part also. So, in last lecture we studied that normal anion gap metabolic acidosis can be remembered with this mnemonic hard up, right? So, with H it was hyperchloridemia. So, in what conditions we can have hyperchloridemia? Either you infuse someone with lots and lots of sodium chloride solution, or you use 3% NaCl, or you are using total parenteral nutrition which contains a hell lot of chloride ions. So what happens is, in your extracellular fluid or your blood, the concentration of chloride goes up. The moment the concentration of chloride goes up, you lose bicarbonate. It goes down, right? When you lose bicarbonate, with our old equation, if you lose your bicarbonate, this equation, to bring itself to equilibrium, will shift its direction towards right side. So there will be more of H ions, right? As HCO3 goes down in response to hyperchloridemia, your equation will shift towards right side so as to maintain an equilibrium. Therefore, the absolute concentration of H ions will increase, and that is the reason of metabolic acidosis, which is normal anion gap. Why it is normal anion gap? Because anion gap is technically sodium minus chloride plus HCO3. So here, if chloride is going up, HCO3 is going down. So this part remains static. If this part is static, the sodium is static, the anion gap won't change. The organic acids are not increasing. It's the problem with chloride here. So that is the reason you have normal anion gap metabolic acidosis when you infuse someone with 3% NaCl or saline, or you are doing hyperalimentation by giving total parenteral nutrition. With A, it was acetazolamide or any other drug which causes bicarbonate urea. Means when you give acetazolamide, the urine contains significant amount of bicarbonate. You are secreting bicarbonate in your urine because of acetazolamide. So the same principle applies. Bicarbonate goes down, the equation shift towards right side. Absolute H ion concentration increases, and there is normal anion gap metabolic acidosis. Right? Third comes renal tubular acidosis. Just pay attention to renal tubular acidosis. It's slightly complicated. There are 4 types of RTA. There are 4 types. We are not worried about type 3. We are only worried about type 1, type 2 and type 4. So we will be putting our emphasis on type 1, 2 and 4. So type 2 is proximal RTA. Proximal RTA is type 2. The pathology is in proximal convoluted tubule. The pathology lies in proximal convoluted tubule. What does PCT does? PCT helps in HCO3 retention. Means whatever HCO3 filters from your glomeruli comes to your PCT, it gets reabsorbed. So the cells which are responsible for reabsorption of HCO3 in proximal convoluted tubule have a pathology. So thereby there is efflux of HCO3 in the ultrafiltrate. You have lots and lots of HCO3 in your ultrafiltrate. If HCO3 goes up in your ultrafiltrate, the osmolality of the ultrafiltrate goes up. So there will be increased water and salt secretions from outside to inside. The absolute HCO3 concentration is high in the ultrafiltrate. So because of that, fluid and sodium will be attracted into the ultrafiltrate. So what will happen? There will be sensing of GJ cells, juxtaglomerular cells, JG cells. They will sense that your effective circulating volume is less. So what will happen? Renin will be secreted. If renin is secreted, your angiotensin system will get activated. If your angiotensin system is activated, you secrete aldosterone. Right? When you secrete aldosterone, aldosterone acts on your collecting duct. And what does aldosterone do? It conserves sodium and excretes potassium. So sodium is conserved and potassium is excreted. So the end result is you are excreting lot of bicarbonate and lot of potassium. So there is hypokalemia. So I'll repeat it again. Proximal RTA, the pathology is in proximal convoluted tubule. There is less effective absorption of bicarbonate. So ultrafiltrate contains lots and lots of bicarbonate. Because of high amount of bicarbonate in the ultrafiltrate, there is a secretion or there is a absorption of sodium and water into the ultrafiltrate. Because of that, your effective circulating volume goes down. If the circulating volume goes down, the JG cells will be activated. They'll secrete renin. Angiotensin aldosterone system will be activated. This aldosterone will act on your collecting duct, wherein it will promote sodium reabsorption and potassium excretion. And that is the reason that in proximal RTA you have hypokalemia. Right? Now we come to type 1 or distal RTA. Type 1 or distal RTA. So the problem is in distal convoluted tubule. We have a cell known as alpha intercalated cell. Right? We have a cell known as alpha intercalated cell. Alpha intercalated cell, it has two pumps, hydrogen ATPase and hydrogen potassium ATPase. So what does in normal circumstances alpha intercalated cell is doing? It is secreting protons. It is secreting protons and it is retaining potassium. That means this alpha intercalated cell will secrete HIN into your ultrafiltrate and it will reabsorb potassium inside. Now there is a problem in alpha intercalated cells. So what will happen? This H ion won't get secreted, so it will be retained. Similarly, potassium ion won't be absorbed, so it will be in ultrafiltrate. So the end result would be high proton concentration in the cells and in the extracellular fluid, giving rise to acidosis, and potassium being in your ultrafiltrate will be given out in your urine. So there will be absolute decrease in the potassium ion concentration. That is the reason you have hypokalemia in renal tubular acidosis type 1 also. Getting the point? There is no problem with HCO3 here. The problem is in alpha intercalated cell, which is unable to secrete proton and unable to retain potassium. Right? Now we come to type 4 RTA. In type 4 RTA, the mechanism is that there is a problem in alpha intercalated cell plus there is a problem in principal cell. What happens is that there is no absolute problem in principle. The problem is that type 4 RTA is basically a problem whereas you have less secretion of aldosterone. Say for example, you have destruction of adrenal cortex because of any reason. You secrete less cortisol, you secrete less aldosterone. So this less aldosterone will not be able to function properly on principal cells. If it is not functioning properly on principal cells, what will happen is that it helps in secretion of sodium and potassium. Aldosterone acts on principal cell, sodium is retained and potassium is excreted. This is the normal functioning. Now here what is happening is because of lack of aldosterone, sodium is excreted, potassium is retained. This is the mechanism of principal cell. Aldosterone acts on principal cells and retains sodium and excrete potassium. But because of the absolute decrease in concentration of aldosterone, the principal cells are unable to, retain sodium. So sodium is excreted into your urine and potassium is retained. So that is the reason type 4 RTA comes to you with increased potassium or hyperkalemia. Right? And because of the alpha intercalated cell, you have increase in proton concentration also, as we discussed about type 1 RTA. So you have acidosis and you have hyperkalemia. So type 2 and type 1 comes to you with hypokalemia, type 4 comes to you with hyperkalemia. Now D is for diarrhea. See, our intestinal fluid is rich in bicarbonate. It is rich in bicarbonate. So if you are losing lots and lots of bicarbonate in your stools, so again the same equation, your HCO3 goes down, there is a shift in this equation towards right side, absolute increase in proton ion concentration will be there. You will have acidosis. Then someone has a bladder cancer. So the surgeon, it's anastomos, your ureter with sigmoid colon, ureterosigmoid ostomy. So you have ureterosigmoid ostomy due to bladder cancer. What will happen is urine contains lots of chloride. When it goes into the gut, the chloride is reabsorbed into the blood and HCO3 is secreted. Right? Urine is going into the gut, into your sigmoid colon. It has a very high concentration of chloride. The chloride gets reabsorbed in exchange of HCO3. So absolute HCO3 concentration goes down. Again the same equation applies. The proton concentration goes up and you have metabolic acidosis, which is normal anion gap. Similarly, P is for your pancreatic fistula. Pancreatic fistula. Pancreatic fluid is very highly rich in HCO3. So suppose someone has recurrent bout of pancreatitis and there is a fistula formation in the gut, through the gut, right? So you will secrete lots of bicarbonate, and again the same principle that as soon as you lose bicarbonate, the absolute HN concentration goes up, and that causes normal anion gap metabolic acidosis, right? So this covers most of the reasons. I have added one cause E, small e, so hard up P. So this is early renal failure. Early renal failure. Here what happens is kidneys are unable to retain bicarbonate. So kidneys are unable to retain bicarbonate, and that is the reason you get normal anion gap metabolic acidosis in early renal failure. So principally, if we see, either we have a renal problem or we have extra renal problem when we are dealing with NAGMA, right? So when we have a case where we demonstrate that patient has a normal anion gap metabolic acidosis, how do we find the cause? So we have a logarithmic approach. How? Suppose I see the ABG, I come to the conclusion that my ABG is showing me normal anion gap metabolic acidosis. So I know that either it will be problem will be in the kidney or it will be extra renal, outside kidneys. Only two possibilities are there. So what I will do is I will calculate urine anion gap. Now what is urine anion gap? Urine anion gap is sodium in urine plus potassium in urine minus chloride in urine. Urine anion gap denotes that kidney is capable of secreting ammonium. That means if urine anion gap is absent, if there is no urine anion gap, that means kidneys are working optimally and they are able to secrete ammonium. If your urine anion gap is positive, you are calculating these ions in urine, that means there is impairment of ammonium excretion in the urine. That is the significance of urine anion gap. So when I do a urine anion gap and I see that my urine anion gap is coming out to be positive, so the cause is renal. If my urine anion gap is negative, that means my kidneys are able to secrete ammonium ions efficiently, so the cause is extrarenal. So how to delineate further? So once I have arrived that I have a renal cause, I go and check my potassium. If potassium is high potassium, it is type 4 RTA. Type 4 RTA. Correct? If potassium is low, I have two possibilities. Either I have type 2 RTA or I have type 1 RTA. Now how to differentiate? Just recall that type 2 RTA, the problem was in proximal convoluted tubule and there was HCO3 secretion. So fractional excretion of HCO3 in the urine will be high. That means out of the fraction of secreted HCO3, there will be more HCO3 which will be going out in the urine. If 100 units of HCO3 are secreted, so maybe 20 units are excreted. So fractional excretion is 20%, right? So here fractional excretion of HCO3 is more than 15%, right? You have hypokalemia, you have fractional excretion of HCO3 which is more than 50%. Now recall that it is the problem with PCT. So alpha intercalated cells are normal, proton excretion is normal. That means pH of urine won't change. So pH will be somewhere around 5.3. So if you have a patient of normal anion gap metabolic acidosis where your urine anion gap is positive, you have hypokalemia, your pH is 5.3 or less and fractional excretion of bicarbonate is more than 50%, you are dealing with type 2 renal tubular acidosis. Now recall that type 1 RTA, the problem was with distal convoluted tubule with alpha intercalated cells. So there is impairment of proton secretion. So the pH will be more than 5.3. Now the PCT is normal. So bicarbonate secretion is not impaired. right? So bicarbonate absorption is not impaired, so you have less bicarbonate urea, so fractional excretion of bicarbonate will be less than 15%. I hope this is clear. So we have positive urine anion gap, hypokalemia, fractional excretion of bicarbonate, and pH. By these 4 points we can delineate what type of renal tubular acidosis we are dealing with, right? Suppose the urine anion gap is negative, that means I'm not dealing with the kidney problem, so that means I am dealing with extra renal problem. What could be the extra renal problem? I can have diarrhea, so this will be the history. You ask patient whether you are having diarrhea or not. You ask patient whether you have history of chronic pancreatitis, or you check the medical records. Drug history, acetazolamide, topiramate, all those drugs which can cause normal anion gap metabolic acidosis. Any history of surgery of bladder where surgeon has anastomosed sigmoid colon with ureter. So by history only you can come out to a conclusion that patient has got extra renal type of nagma, right? I hope this is clear. So in next lecture we will be dealing with high anion gap metabolic acidosis and its algorithm of management.